Good afternoon. I want to thank Mei Xian for inviting me to give this talk on caregiving and psychosocial factors in dementia. For those of you who know me, I think for the past 2 or 3 years, I've spent quite a lot of my time trying to support people with early dementia through their illness, as well as their family members. So today I'm happy to have the chance to share with you my experience, my personal views, as well as to be the voice of people with early dementia, as well as their family members. I think as with any initiative or in any organization, there must be always a goal in care or in purpose, some purpose in what we do. And we always tell patients or family members that dementia is not curable, but it's treatable. We can do something for you. But what really can we do for dementia? Here is one view expressed by the late Tom Kitwood. And he in the opinion of many, revolutionized dementia care. And he wrote this in 1997. He said, the primary goal of dementia care is to maintain the personhood of the person with dementia. And you want to treat that person with dementia still as a person. You want to maintain his sense of identity, his sense of self. And if he's still a person, you say, I want to treat him with dignity and respect, the same way I treat any person I care for and love. I want to give him happiness. I want to give him a good quality of life for whatever time he is left with. So dementia care is about meeting basic human needs, isn't it? Physical needs, you have to help them to be pain-free, to feel energetic, to feel good about themselves. Psycho-emotional needs, happiness. Spiritual needs even, because people with early dementia still have this need to search for meaning in life. Because he's a person still with feelings and human needs. And as one of my caregivers told me, he says, my role in looking after my father is to help to keep him intact, his sense of identity, his personality intact, and in touch with the world, in touch with the family members, with people he loves. Here is the voice of a person with dementia. He says, I'm hungry for the life that is being taken away from me. I'm a human being. I still exist. No theory of medicine can explain what is happening to me. Every few months, I sense that another piece of me is missing. My life, myself, are falling apart. Most people expect to die someday, but whoever expected to lose their self first? Now, why are psychosocial factors important in dementia care? I think they're important for two main reasons. Number one, dementia care is not just medical care. It's more than medical care, and we will see a bit more of this in the slides to come. And the other reason, of course, is that psychosocial factors actually affect the presentation of the disease. No two persons with dementia are the same because they come from very different backgrounds. They are different people. Good dementia care improves outcomes, and there's data now to show us this. But quality of care depends on the carer. It depends on what kind of care you give him. Dementia care, however, is often burdensome, painful, and expensive for the family caregiver. It's also for the society. So the first point that I made, good dementia care is not just quality care, quality medical care. Then what is good dementia care? There are two basic models in understanding dementia, and basically dementia arose really from a biomedical model. It's a medical disease to begin with. So what you see in dementia is the result of neurological impairment. However, in recent years, a slightly more holistic model has emerged. They say that, well, it's true that what you see in dementia is a result of brain damage, but there are other factors that are just as important in the presentation and, of course, even the outcomes of the disease. How about the person's past, his basic personality, his life history, meaning his biography? Don't this also affect the presentation of the disease? Are not these factors important in his management? Environmental factors. What kind of physical environment are you subjecting him to? What about the social environment, meaning how do you care for him? How do you talk to him? Is that not important? Would that not precipitate behavioral problems if not done sensitively and appropriately? So let's take the example of a patient who is uncooperative and aggressive during bath. From a purely medical point of view, you would say that this patient has dementia, He's got brain damage. How do I manage the problem? Well, he has brain damage. He cannot think for himself. He doesn't have the insight to see that he has to bathe. I understand from the guidelines that aggression is a known behavioral and psychological symptom of dementia. So his aggression is due to the disease. I follow the guidelines. I medicate him. And according to existing evidence, I choose the best agent for him to reduce his aggression. Would that work? We know in practice that might work, but it doesn't work all the time. And if it works, maybe it works to only a certain degree, 20%, 30% of the problem is solved. If we take the biopsychosocial model, you take a slightly different approach. Instead of saying that I want to manage the problem, you say, I try to understand him. I try to understand why he's behaving this way. Is there something in his past? We know in the wards that we drag patients for a bath at 6 a.m. in the morning. How many of us bathe at 6 a.m. in the morning? If a person has dementia, does he have the ability to inhibit his displeasure and tell you, I'm okay with that, because I understand I'm in the hospital. He cannot see things from your point of view. So he will act out. So the disease, of course, plays an important role. But we have to also examine his basic history, his life history. And then we try to empathize with him. We say, if I was in his position, if I'm dragged for a bath at 6 a.m., how would I feel? This new model also advocates that we try to change the way we communicate in dementia. And to change the way we communicate, we need to change the way we think. The old language says that if this person is refusing personal care, and he acts out his agitation, anxiety, aggression, these are manifestations of dementia. It's part and parcel of the disease. But the new way of looking at it, we say, well, this person still has his old self intact. He can still exhibit a choice. He prefers to do what he wants to do. And he's able to assert himself. So I say he's energetic, he's assertive. He may have an underlying unmet need that I don't understand. Maybe it's time to understand him. Wandering is a common problem we see in dementia. We say wandering is a problem. But is wandering really a problem? If you have a big space that's safe for him to wander, so to speak, it's no longer a problem. And I can see that this person is still seeking, he's still exploring the environment because he's new to environment. He has dementia. He's like a child. He wants to explore. And so instead of saying that we want to control and manage these problems, we say, can I accommodate? Can I respond to his needs? Instead of trying to correct him and expect him to behave according to our social norms, can we say, can I try to connect him? Can I accept him as what he is? And isn't this what we do with those that we care for most? So these principles are actually captured very well in certain management protocols. And one of these protocols is this bathing without a battle. Okay. And this was actually tested and written up in a journal in 2004. And they advocated this form of management of aggressive behavior during bath. They call it person-centered shower and towel bath. And they found that in the treatment groups, agitation and aggression was significantly reduced without the need for any medication. And so you saw, I think Dr. Francis Nui actually showed this just now. In our guidelines itself, on the part on non-pharmacological therapies, we mentioned about enhanced care methods such as person-centered showering and towel bath. So this is what it's all about. To further bring across this point, I want to take the example from this book, which is just published in December last year. The Person in Dementia, this was written by an anthropologist. She actually spent 2 years, Athena McLean, doing an ethnographic study of the lives of elderly with dementia staying in nursing homes. Ethnographic study means she actually immersed herself into the culture of nursing homes and tried to understand what it was like for an elderly to stay in a nursing home. And she compared these two approaches to care, the old biomedical model, which is very task-oriented in approach, and the more flexible person-centered model based on individual needs and communication. And what did she find? She found that the old one that focused on medical pathology, disability, often ignored personal needs. Patients were heavily medicated, often unnecessarily, and they failed to thrive. We know the side effects of these medications. but the one that focused on human needs, communication, over and beyond physical and reasoning abilities, they had a better quality of life, and they lived longer. So she says, these findings address issues that medicine can't answer. They are valuable not only for improving the general quality of life for these elders, but also for the long-term outcome based on how they are treated and cared for. These elders require attention, time, and a lot of caring interaction. I want people to see that dementia need not evoke the terror that the term Alzheimer's usually raises, and that there is still hope in cases that many think are lost. Going on to the second point. Now, we know quality of care depends on the carer, and there's some data now to show us that good care can improve outcome. However, and it's a big however, it's a big but, care is provided by the family caregiver or the former caregiver in nursing home. To be able to provide this kind of care, they need education, they need skills training, they need to be supported. Do they have a system that is supportive of this kind of care? What's necessary and most basic in dementia care? I think, in my opinion, once a person has gone a little beyond the early stages, bordering on the middle stages, when they lose executive function, they lose the ability to plan and think for themselves, I think you need then to structure the day for them in a calm, secure, and familiar environment. They need regular engagement on a human level and with nature. They need activities to provide constant engagement, enjoyment, and a sense of meaning and purpose in life. All this done to maintain integrity, dignity, and self-esteem. Isn't this what we all need? This is the executive summary of the NICE guidelines, just released in November 2006. And I just want to point out to you that this was developed by NICE, as well as this Social Care Institute for Excellence. So I think they have come to actually realize that dementia care cannot be approached from a purely medical point of view. There is a need to involve people from social work as well. And what do they say in the guidelines? I quote from one part of it. They say people with dementia should participate in structured group cognitive stimulation programs, irrespective of any anti-dementia drug. And so in our guidelines we say, it has been shown that a structured, social, and modestly stimulating environment provided by a dementia program, often offered in daycare centers and some nursing homes, can improve the well-being of people with dementia. What is some evidence for this? This is taken from a website in the UK, the Cognitive Stimulation Therapy Program, developed in the UK by Amy Spector's group. What did they do? What is a cognitive stimulation program? What we do in daycares, physical activities, sound, music therapy, childhood meaning reminiscence, reality orientation, current affairs, reading newspapers to them, some cognitive exercises, and in our context it may be mahjong, using money. The study based on this kind of care was published in 2003, and they compared treatment groups with usual care, and they found that there was a marginal improvement in mental state examination. But more importantly, quality of life by the QOLAD was better. And there are very few studies that actually can show improvement in quality of life. And of course, what's the advantage of this? No drugs, cheaper, no side effects. This was reported in the New York Times a few years ago. Exercise and setting ease Alzheimer's effect. What is the basis for this? Based on Linda Terry's paper in 2003 in JAMA, she examined the effects of exercise and behavior management in dementia care. And what did they find? They found that those who had exercised had better physical function, quite intuitively we understand that, and also lower levels of depression post-treatment. So, look beyond maids in the care of the elderly. Can maids provide this kind of care? Probably not. No? The third point, dementia care can be burdensome, painful, and expensive. Family caregivers, we know for many of us who work in the dementia circle, family caregivers experience great burden. And a distressed and burdened carer cannot provide good care. There is data to show that a distressed carer is associated with increased behavioral problems. Of course, you could see it's the other way around also. Increased behavioral problems can result in distressed carer. These patients are often over-medicated. There's increased hospital admissions, premature nursing home institutionalization. What do family carers need if they want to provide care? First, they must know the goals of care, which we enunciated earlier on. They must have a desire to care. You know, I think in clinical experience, that not every family carer has the same desire to care for their relative with dementia. They need to have knowledge and skills, and you need to support them socially and financially. Very important. Money talks.